Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our wonderful guest from China, Prof. Li Qiang. Dr. Qiang is an associate professor and deputy director of Neurovascular Center, Shanghai Hospital. He is a committee member of the Shanghai Neurosurgical Society as well as of the Shanghai Medical Association, Chinese Federation of Interventional Clinical Neurosciences, China, and his research and clinical interests are focused upon the management of cerebrovascular disease by endovascular techniques. We are extremely honored to have him today at our webinars, and today he will be talking about flow diverters for aneurysms in China. The speaker for the second session of today is our honorable guest from the UAE, Dr. Tarek Rayan. Dr. Rayan is a consultant neurosurgeon, cerebrovascular and skull-based lead at the Sheikh Shakbout Medical City, Abu Dhabi, UAE. He was a previous consultant neurosurgeon and associate professor at the Department of Neurosurgery at the Alexandria School of Medicine, University of Alexandria, Egypt. He was a member of the Young Neurosurgeons Committee of the WFNS. He did his clinical fellowships in cerebrovascular surgery at the University of Illinois at Chicago, followed by International Neurosurgery Clinical Fellowship from the Mayo Clinic, Rochester, Minnesota. He was also a skull-based and neuro-oncology cranial neurosurgery fellow at the Mayo Clinic from 2015 to 16. He is a noted author with several publications in various peer-reviewed journals, and we are extremely honored to have him today at our webinars. And today we will be talking about the utility of transpetrosal approaches for CP angle and petrosal region tumors, assessing the outcome based on the extent of resection and cranial nerve. The chair for the first session of today's webinar is our honorable faculty from Japan, Professor Makoto Sakamoto. Professor Sakamoto is an associate professor at the Division of Neurosurgery, Department of Brain and Neurosciences, Faculty of Medicine, Tottori University, Japan. He is an important member of the Japan Neurosurgical Society as well as the Japanese Society for Neuroendovascular Therapy. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable guest from Brazil, Prof. Luis Borba. Prof. Borba, who is a world-renowned skull-based surgeon, is a professor and chairman, Department of Neurosurgery, Evangelic Medical School, Curitiba, Federal University of Paraná, Brazil. He is also the professor honoris causa of the Sechenov Medical School, Moscow, Russian Federation. He was the past president of the Brazilian Neurosurgical Society and is the current president of the FLANC, which is the Latin America Federation of Neurosurgical Societies, as well as the president-elect of the World Federation of Neurosurgical Societies. He was the president of the World Skull-Based Societies previous meeting in Colombia, Bogota in 2022. We are extremely grateful to him for accepting our invitation to chair the session of Dr. Rayan. On behalf of the Education Committee of the ACNS and the President Prof. Yoko Kaito, I would like to welcome both the speakers, chairs, and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Prof. Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Prof. Makoto Sakamoto.
Hello, good evening, everyone on the web. Welcome to the first session of the ACNS webinar. My name is Makoto Sakamoto, and I'm from the Department of Neurosurgery at Tottori University in Japan. It's a great honor for me to be the chair of this meeting, and I would like to express my thanks to Professor Kato and Professor Raja. Flow diverter treatment is a safer and less retreatment procedure than coiling for unruptured aneurysms. However, mastering it requires knowing some tips and pitfalls. Today's presentation is titled Flow Diverters in Aneurysm in China and will be given by Professor of Shanghai Hospital, Li Qiang from China. Okay, would you start your lecture, Professor Li Qiang?
Sure. Thank you. Thanks for the chairman, and thanks for Dr. Bing Xu and Dr. Kato for invitation. It's my great pleasure to speak here, and it's a fantastic platform for discussion. And today, my presentation, the topic of my presenting is flow diverter for aneurysm treatment in China. I'm Chang from Shanghai Hospital, which is located in Shanghai and China, and we are the hospital which is affiliated to the Naval Medical University, and I'm a member of Dr. Jiaming Liu team, and we are dedicated in the cerebrovascular disease treatment for more than 30 years. So let's begin my presentation. This is my disclosure. And as we all know that flow diverter has been used for treating aneurysm for about more than 10 years in China. And before the launchment of the flow diverter, that is before the 2013, and we are keeping treating the aneurysms, not only the ruptured ones, but also the unruptured ones use the coiling and stent-assisted coiling and balloon-assisted coiling and so on. And we are the first center in the Asia to using the stent-assisted coiling, not only in China but also in the Asia. But before 2013, and these are the only mortality for the treating aneurysms. And after the launchment of the fourth generation pipeline in 2014, and we are beginning to use the flow diverter in treating aneurysms. And just last year, the new generation, which is the third generation pipeline shield, has launched in China, and we are beginning to use this kind of new pipeline, new flow diverters now. But before the launchment of the flow diverter in China, we have our domestic flow diverter that is called the Tubebridge, which is produced by the Microport company, and along with our center, with the chairman of our center, Dr. Jianming Liu, that is the domestic flow diverter, and we began the first immense study in 2008, and published the results in 2014, which showed that it is effective and safety devices in treating the large aneurysms. And we began the parrot study, which is compare the flow diverter and stent-assisted coiling in treating a large or giant aneurysm, intracranial aneurysm, and that is called a parrot study. And we published the result in 2018 in the ACNS, which shows that the significant better results in the flow diverter arms. And we begin the producing of the domestic flow diverter, which is called Tubebridge, in 2005. And after 13 years of research and development, and we got the approval in 2018. So now in the Chinese market, many flow diverters are available now. Not only the international companies produce the flow diverters, that is the Pipeline, and the Surpass, and the Evolve, and the Fred, and there are more than up to now, that is not at least 5 flow diverters have been available in the market. That is Tubebridge, Lattice, Luva, Reapers, and Chilling. These are all the domestic flow diverters. And as far as I know, there are more than at least 4 new flow diverters are coming into the market now. And we have been using the flow diverters for the large aneurysms, just as these patients with the large cavernous sinus aneurysm, which is treated with the Pipeline. And we after the 6-month follow-up, not only the aneurysm is disappeared on the DSA, but also you can see from the MRI the dome of the aneurysm shrink in the MRI follow-up, and but also in the small aneurysms, which is treated by the flow diverters, and which make this treatment more easily and safely. And by evaluating the result of the photodiverters treating the aneurysms, many Chinese physicians have gathered their data to perform a big study. And this study is raised by Dr. Yang Qingjian in Beijing Tiantan Hospital, which is the largest cohort of the aneurysm treatment using the pipeline. And you can see from the study, altogether more than 1,000 patients with over 1,300 intracranial aneurysms were included. And the total occlusion rate was over 80% at the mean follow-up of the over 8 months. And during in their patients, about 77% of the aneurysms was treated by the pipeline alone, and others are treated by the photodiverter plus coiling. And you can see from these images the distribution of the features of the aneurysm. You can see about half of the aneurysms are small aneurysms, and over half of the aneurysms are large or giant aneurysms, and most of the aneurysms are specular aneurysms. And you can see from the location and the morphology and the aneurysm can reflect the real world treatment for the aneurysms. And there are indeed there are some procedural complications, which include ischemic complications and some hemorrhagic complications, but these complications are acceptable. And you can see from the class study, and these are the predictors for the aneurysm occlusion. And you can see from their from this forest plot, and you can see in the total cohort the history of the subarachnoid nodal hemorrhage, and the aneurysm, the maximum diameter, and the morphology of the aneurysms, and if the aneurysm was treated with or without coiling are the predictors for the aneurysm occlusion. And how about the small and medium size of the aneurysms in the photodiverter treatment patients? And you can see this is the subgroup analysis of the PLUS study, and you can see from these about 1,652 patients with 1,754 aneurysms, and you can see there are the photodiverter was successfully deployed into about 100% of the patients, and 60% of the patient was using their pipeline alone, and most of the patient got the complete wall occlusion. And you can see from the medium follow-up of 7 months, over 82.5% of the aneurysm was totally occluded. And there are the main concern of the is the standardizations, and you can see from this slide that only about 1.4% of the patients got the stenosis over 50%. And we got a major ischemic stroke in only 1.8% of the patients, and very small amount of the patient got the hemorrhagic and complication, which shows that in the small and the medium size of the aneurysm, the flow diverter treatment for the aneurysms is safety and efficient. And how about the local, the domestic flow diverters? Dr. Jianming Liu, which is chairman of our center, has raised a study which is called TRACE-IA, and this is only focused on the tube bridge, which has been used in China, and which is occupied the second place in China concerning the flow diverter. And you can see from this image that most of the patients got a very good result. And how about the anti-grade trial for this specific flow diverter? And you can see from the impact trial, which is the registry post-market trial for this specific flow diverter, and you can see that this is the distribution of the size of the aneurysm. You can see from this image that most of the aneurysm we treated using this tube bridge flow diverter is small aneurysms, and about 30% of the aneurysms are large or giant aneurysms. And you can see that for the aneurysms, about over 80% of the aneurysm got complete occlusion, and most of the patients get a very good result. And so you can see not only the international company produced the flow diverter, but also the domestic flow diverter are very safe and efficient for the aneurysm treatment. And how about the off-label usage for the flow diverter? And we are keeping using these flow diverters for the dissecting aneurysms, post-seclusion aneurysms, distal vessels aneurysms, and the recurrent aneurysms, but also and the ruptured aneurysms, especially in the blood blistered aneurysms. And you can see from this image that the dissection aneurysms of the vertebral artery, and we have used pipeline plus coiling for this aneurysm and got a very good result in the 3-month follow-up. And for the small and medium vertebral artery aneurysm, and these are the subgroup analysis from the PLUS trial, and you can see that altogether 76 patients with 78 unruptured small and medium vertebral artery aneurysm has been collected for this trial, and which were enrolled 14 centers in China has been enrolled in this study, and you can see that complete occlusion of the aneurysms happened in 9.6%, and nearly 100% of the patients got a good prognosis. And ischemic stroke occurs in 10.5% of the patients, and adjacent coil is a predictor for the postoperative ischemic stroke. And some physicians will be concerned about their whether their pica covered by the flow diverter may cause ischemic stroke. And from this study, you can see that there is no significant difference in the ischemic stroke between the patients, between their pica covered or not covered by the flow diverter. And for the specific dissection aneurysm, that the result is similar to this. And we have used the flow diverters in very distal small vessel aneurysms. And you can see here is the A3 dissection aneurysm, and we put a pipeline and in the small distal small vessels, and you can see that from the 9 months follow-up, the vessels with reconstructed, and the aneurysm is totally occluded. And we have done a systemic review and meta-stasis in these very distal and small vessels. The procedure-related mortality is a little higher than the proximal vessel aneurysms, but the overall long-term result can be acceptable, and the complete occlusion rate for the saccular aneurysms was lower than that of the non-saccular aneurysms. So we prefer to treat the dissection aneurysms in the distal vessels using the flow diverter. And this is our single centered experience of using the flow diverter in treating distal small vessels. And you can see that 28 patients with 28 aneurysms was included. And you can see that in their a relatively short term follow-up, only 61.5 complete or nearly complete occlusion of the aneurysms was got, and there are about 23.1 incomplete occlusion and 15.4 unchanged. And you can see that the existence of the perforators derived from the aneurysm was associated with a lower occlusion rate. And we also got peri-operative complication about 7.1%, and there are still some delayed complications. And from the literature, if the modification of the flow diverters has been done, and that is if we switch the FRED to FRED X, that is the surface modification of flow diverter, and we will got a lower ischemic complication. So surface modification flow diverter may be better for the small vessel aneurysms. And for the ruptured aneurysms, especially for the blood blister aneurysms, we have been using the flow diverters treating these kind of lesions. This is the blood blister aneurysms, which has been treated using the pipeline plus coils. And you can see from the 3 months follow-up, the aneurysm is gone, and the parent artery has been well reconstructed. And this is the patient of the blood blister aneurysm, which is being treated by the two-bridge flow diverter. And you can see from the 3 months follow-up and the 6 months follow-up, the aneurysms has been totally occluded, but there are slightly stenosis of the in the flow diverter. But you can see from the 6 months follow-up compared with the 3 months follow-up, the stenosis is getting better. And you can see from the images that we are we prefer to use the flow diverter plus coiling for this kind of specific lesion, and to avoid early rebleeding. And we prefer to use the semi-jetting technique to deploy the flow diverter, and using another catheter to pack some coils into the dome of the aneurysm. And this is another patient which is being treated by the tube bridge plus coil. And some Chinese physicians have published this kind of technique, which is called semi-deploying technique for the flow diverter. And you can see from these case series that most of the patient has been using the flow diverter plus coils, and most of the patients get a good result, except in one patient. And from this small case series, all the patients has been treated using their flow diverter plus coils, and all of the patients get 6 months to 1 year angiographic follow-up, and got a very good result of the aneurysms, and but also the clinical follow-up for these patients. How about the recurrent blood blister-like aneurysms, which has been treated by the stent-assisted coiling? And we have published our own experience, and you can see here from the publication, we have collected cases in the previous 3 years. Altogether, 13 patients has been collected, which has been treated with blood blister aneurysm and recurrent. And these aneurysms has been previously treated with the stent-assisted coiling. And we used 2 tube bridge flow diverters and 5 pipelines to treat these patients. And in 11 of the patients, a single flow diverter alone was used, and 2 of the patients was treated by the using further coiling plus flow diverter. And in the 12 patients which has been got angiographic follow-up, all of the patients have got a complete occlusion, and no perioperative complication, and no rebleeding was observed in the other patients. And from these images, you can see the patient was treated by the Enterprise plus Airways stent-assisted coiling, but the aneurysm reoccur during the follow-up image, and the patient was retreated using tube bridge flow diverter alone, and 1 month follow-up shows the aneurysm was totally occluded, and the parent artery is patent. And not only in the recurrent blood blister aneurysms, but also in the recurrent circular aneurysm. You can see here is the large aneurysm, which has been treated using the stent-assisted coiling, which is previous cases. And we can also using the flow diverter to treat these kind of the patients, and got a very good result. And how about the bifurcation aneurysms? And this is the MCA bifurcation aneurysms, which is treated using the pipeline plus the coil. And you can see from the 17 months follow-up, the aneurysm is a little bit enlarged, and after we stopped the antiplatelet therapy for 10 months, And the follow-up image shows the total occlusion of the aneurysms and the reconstruction of the parent artery. But you can see that the branches from the dome of the aneurysm has been occluded. And for very complicated aneurysms, we can also using the telescoping flow diverter for this kind of patient. This is a communicating segment aneurysm, and you can see the parent artery was totally involved in the dome of the aneurysm, and we used two pipeline to do the flow diversion, and using the telescoping technique. And you can see this is the first pipeline, and this is the second pipeline. And after that, we coil the aneurysms to support the two flow diverters, and then using the micro wire to do the massage for the flow diverter to facilitate the complete wall opposition. And you can see from here, this is the immediate post operation. The parent artery is well reconstructed, and the contrast stays in the dome of the aneurysm. And you can see from the 6 months follow-up, the aneurysms is really complicated, occluded, and the parent artery is patent, and the patient is neurological intact. And we have done a lot of patients complicated aneurysms using the telescoping flow diverter, not only using the flow pipeline, but also using the two bridges to these complicated cases. But even by using these new devices, some problems remain. Which is the ischemic event after the flow diverter, even very late parent vessel occlusion. And for the vertebral basilar aneurysm, especially for the vertebral basilar dolichoectasia, it is very complicated cases even for now. And for some bifurcation aneurysms, some persistent filling of the blood will happen, and the delayed rupture of the aneurysm is also another problem. Just for these cases, and you can see that from the 6 months follow-up image, the result is very good. But after 3 more months follow-up, the patient got a sudden weakness in the right limb and aphasia. And from the follow-up image, you can see the total occlusion of the ICA, and there is acute large infraction of the frontal lobe, and that is the total occlusion of the parent artery. And for the vertebrobasilar dolichoectasia, this is very complicated cases, and we can using a pipeline or multiple pipeline flow diverters for to reconstruct the vertebrobasilar artery, and we can get a very good image about some infection of the brainstem will happen, and this will cause a big, very significant consequence for the patient, and we have got even a very bad prognosis. So some physicians in China have compared their braided stents, conventional braided stents, to the effect of the flow diverters, and you can see that only about about 60% of the patient got a good clinical outcome, and we got about 10% of the patient got neurological death, and higher rate of the new neurological deficit was due to the procedural complications in the flow diverter group. But in the flow diverter group, you can got a higher rate of complete occlusion. But the result is the complication rate is higher. And for some bifurcation aneurysms, especially, there are very important branches arising from the aneurysm. Especially, there is no compensated filling supplied to these branches, and the persistent filling of the contrast will happen. And just like this patient, you can see that after deployment of the flow diverter, the dome of the aneurysm shrinks at the 9 months follow-up, but after the 21 months follow-up, you can see the enlargement of the dome of the aneurysm. And I performed a bypass surgery for this patient to treat the aneurysm. And instant stenosis is also a big concern by using the flow diverter. In the PLAS trial, and you can see that a significant instant stenosis happened in about 10% of the patient, but fortunately only 1/6 of the patient is the severe stenosis, which need to the canonized. And we can see that the current smoking history and the cerebral atherosclerosis were independent predicted for the instant stenosis. And the delayed aneurysm rupture is also a problem. And you can see from this patient that after only 6 hours after the deployment of the flow diverter, rupture of the aneurysm happened. And in the metastenosis, about 2% of the patient will take place the delayed aneurysm rupture. But for the giant aneurysm, about 10% of the hemorrhagic complication will happen. And these are the possible mechanisms of the delayed rupture of the aneurysm. One is the pressure raised after the flow diverter implantation in the aneurysm, and the other is the residual blood flow after the flow diverter implantation. And what's more, for the flow diverters we are using today, extensive anti-platelet therapy will needed for these patients. That will maybe another factor for the delayed rupture. And so if the surface modification may solve the problems, and these are the shells. The technique will got a very lower complication rate and similar occlusion rate for the aneurysms. And there are some preliminary experience of using the single antiplatelet therapy for the deployment of the flow diverter, and these are the good news for the using the flow diverter. But by using this, we must got new modification techniques. So for the future of the flow diverters, we need a new structure and new surface modification, maybe new materials, and a longer size of the flow diverter, and may be we can get a better result for the aneurysm treatment. Thank you.
Dr. Sakamoto?
Thank you for your excellent lecture, Professor Kiang. I was so much impressed by your fascinating presentation, and I was surprised to know so many local flow diverters in China. FD plus coiling is not approved by insurance in Japan. How about China?
You mean the flow diverter plus coil?
Yes, flow diverter plus coil is not approved by insurance in Japan. How about China?
Okay. In China, the physicians will decide how to treat the patient, especially in the patients that we are worried about. We worried about the delayed rupture, so we may using the flow diverter plus coil, especially for the very large giant aneurysms with a narrow leg. Yeah, and the large aneurysm with irregular shape, and for the blood blister aneurysm or even other ruptured aneurysm, which in which the flow diverter would be needed to treat the patient. So we have really to use the coils plus flow diverter in China, and it has been proved by the government insurance.
Yes. Okay. You said flow diverter for vertebropatellar dolichoectatic aneurysm is so many ischemic complications. I've read the paper about postoperative anticoagulation is reported to be effective for avoiding ischemic complications. How do you think about this?
You mean the vertebropatellar the artery aneurysm?
Dolichoectatic aneurysm for
yes. In China, now we are using a longer flow diverter, which is the domestic ones, for the first measurement for this measure for this completed lesion. One is the one is using a longer flow diverter, and we are avoiding to using the telescoping, using the multiple flow diverters. This is the first measure, and the other one is to using the dural antiplatelet therapy plus anticoagulation therapy, and that may to reduce the rate of the thrombosis, and that will maybe we have not got the accurate data, but we are using this kind of measure now.
Okay. Now let's open questions and comments from the audience. Do you have any questions or comments from the audience?
Yes, we have a couple of raised hands. First, Dr. Ben from Hong Kong. Ben?
Yes, hello, Professor Lee. Nice to see you here, and thank you for your lecture. And very promising studies of the local brand of the flow diverter. I would like to ask about the ischemic complications. In your case sharing, you mentioned there is use of the aspirin and also possibly dual antiplatelet. Do you track the ARU and PRU, and how do you modify the antiplatelet regime? Can you share with us the antiplatelet regime and any need to monitor the ARU and PRU?
Okay. No, we're not. Sorry. We sometimes we are doing the test to that is the TEG to make sure that the dual antiplatelet therapy is efficient for the patient, and in some patients, some physicians will do the verify test, and some patients will, some physicians will get the genotype for the patient to see whether the clotopid is can whether the clotrimazole is efficient for the patient. In our center, we usually do the TEG for the patient, especially for the patient who was prescribed by the aspirin and clotrimazole. If the TEG is not good for the patient, we will switch to the ticagrelor for the patient.
Yes, thank you so much.
Thank you very much. Yes, Shahnawaz has joined us from Bangladesh. Yes, Shahnawaz.
Excellent presentation and a lot of challenging cases. Just two questions. For giant aneurysm, like in case of MCA bifurcation aneurysm, is there any experience of doing stage procedure, like you coil first, then after a few days you did the flow diverter, or you do the coiling and flow diverter at the same stage? This is number one. And number two, in case of blood blister aneurysms involving the supraclinoid carotid, do you also prefer flow diverter? I mean, any experience of flow diverter deployment in blood blister aneurysm?
Okay, I see. And we never do the flow diverter plus coiling in the vertebral basilar aneurysm in the same stage. We, if it is needed, we will, only when we are planning to occlude one vertebral artery. If it is needed, if the occlusion of the contralateral vertebral artery is needed, we will do occlude the vertebral artery using the coils, and we will reconstruct the other vertebral artery and the basilar artery in the same stage. If not, we will not to do in the same stage.
Okay, thank you. And what's your experience regarding outcome of a flow diverter in blood blister aneurysm?
You mean in the blood blister aneurysm?
Yes.
We prefer to using the coil plus a flow diverter.
Okay.
Because by doing this, we never got re-bleeding for these complicated aneurysms.
Okay. Thank you very much, Dr. Shahnawaz, for this question.
May I say something?
Prof. Baba, you're here. Thank you.
Yeah.
Sorry.
Please.
Sorry for the delay. I'm in the airport. You see, my flight was delayed. I think the flow diverter will come to stay. The technology is coming better. You see now the new flow diverter that they are developing in China and around the whole world. But you still have a big dilemma that the aneurysm that bleed, you put the flow diverter, is not totally protect. Maybe it can bleed. And to avoid ischemic complications, we need sometimes to anticoagulate. Yeah. How to manage this dilemma today is the big issue in my view. And I don't know how you can solve this, especially ischemic complication and the time to do the flow diverting. In the acute phase of a blister aneurysm, I don't know how you can put coils there because it's so small that sometimes you cannot put even the clip. See? And the flow diverter, in theory, should be a good idea, but is not totally closed. How to manage this acute and bleed aneurysm in the acute phase, especially this is small one that you don't have a good neck, you don't have a cannot put a coil, the coil go in and go out. How to manage this?
Sure.
Well, rupture is okay. You can go there and play. But rupture aneurysm is the biggest problem.
Yeah. If you read our publications in the previous years, that we are treating the blister aneurysms using the multiple stent assisted coiling, you will see how we are treating the aneurysms using the stent assisted coiling. We two catheters is using, and one catheter is directing to the dome of the aneurysm. Even though the aneurysm is very tiny and there is no obvious neck of the aneurysm, we can shape the microcatheter to direct the tiny dome of the aneurysm, and on one or two very small and soft coil can be put into the dome.
You need to anticoagulate or not?
No, we do not do the anticoagulate, but antiplatinate.
Yes, antiplatinate. Yes, I'm talking about the same thing. Okay, but this will increase the possibility to bleed, to treat the ischemic thing. See, you are in dilemma. You have a bleed aneurysm. You put the coil, you put the stent. You need to antiplatelate. Yes.
Yeah.
If when you do that, the aneurysm is not totally covered. We know that there is some time to see. This is the issue that we need to understand. It's the most difficult situation. And congratulations for the wonderful presentation. Congratulations.
Yeah. This is our concern, that if we only deploy the flow diverter, and some blood will also goes into the dome of the aneurysm. So we prefer to put some coils, and that may lower the hemorrhagic complication after the deployment of the flow diverter, even when we are using the antiplatinate therapy. That is our concern.
Thank you.
By doing this.
Thank you.
Yeah.
Well, thank you very much. It was indeed an awesome presentation. Now we'll move on to the second session. Before that, I would like to invite Prof. Sakamoto to give his concluding remarks. Prof. Sakamoto.
Yes. I appreciate your nice presentation. And last question, I'd like to have a last question. What will you do when the aneurysm after FD is not achieved the satisfied occlusion? What will you do when aneurysm is not satisfied occlusion? Yes.
Okay.
After FD.
Okay, sure. And in most of the cases, we will wait, because when we are keep following the patient, the aneurysm will got a practically occlusion after 6 months, 1 year, 3 years. More aneurysms will occlude this spot. And two, and we will see which is the reason for the patient for the aneurysm for keeping unoccluded. If the photodiverter is the wall opposition of the photodiverter is not good, we may using some measurements for the by the balloon and other measures and maybe after 2 or 3 years, the aneurysm keep open, and we will maybe another fluid diverter will put for the patient, but we seldom doing this. And the third, if there are some branches arising from the aneurysm, that may be the reason for the aneurysms keep open. And maybe we, in some of the cases, we will stop the antiplanetary therapy, and we will get a very good result, just like the bifurcation aneurysms I presented. But that
Thank
is
you. Yes.
yeah, that will the some complications will happen.
Thank you. I see what you mean. So it's time to finish this session. Thank you so much.
Thank you.
Well, thank you. Thank you very much for this wonderful lecture. And before we move on, I would like to mention to our viewers that this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 860 people who have logged in on different channels from around the world. So thank you very much. So now I'll move on to the second session, and I will hand this podium over to our Honorable Chair, Professor Luis Borba. I will say a short introduction about the utility of trans-petrosal approaches and invite Dr. Tarek Rayhan for his lecture. Professor Borba, all yours.
Thank you, Raja. Thank you, ACNS. Thank you, Professor Kato, for the wonderful job that you are doing the education, not only to Asia, but to the whole world. I really appreciate all your support in our missions. I count on all of you to continue this medical education for the next years. When you have somebody talk about Petrosal approach, also use the Petrosal bond as a root. Today, the people say, no, you don't need more. I don't need temporal. I don't need Petrosal approach. I don't need to understand. We need to know. But does not mean that we need to use to every case. When I start this skull base in the 90s, we are open from here to the neck to reach a small lesion. Now you know the way to go. And the petrous bone is one of the roots, that you can use to reach several areas. To understand the real utility of the Petrosal approach is the most important thing today. I'm very pleased and happy to see here my friend Tarek Rayhan. He's a great neurosurgeon. The guy have a great experience. He can show us how to use, not maximize, not minimize the real point. This is what you need to know in the whole skull base, in the whole neurosurgery. We don't need big incision. We don't need small incision. We need the right incision. It's the same thing with the approach. Thank you very much. I'm here to listen to your presentation. Thank you very much.
Thank
Please,
you.
Tarek.
Thank you very much, Professor Borba, for the very nice introduction. I would like to thank Professor Raja for the kind invitation, and it's a pleasure to be here with the ACNS webinar series. And so my topic today, as Professor Borba alluded, is the utility of the Petrosal approach for lesions in the CP angle and the petroclival areas. And my interest in showing some work done in this area is just to find the comparison between the retrosigmoid and the Petrosal approaches in some selected cases as for the extent of resection and the functional cranial outcome. And as Professor Borba alluded, it's not about big incisions or smaller craniotomies or the extent of the approach. It's always about a tailored approach to the lesion that is present in the petroclival and the CP angle. And my disclosure, no financial disclosures for this topic, but the images and the diagrams here are from the Jackler's Atlas. They're available for everyone on the online website, and the cadaveric dissections are from the famous Roten lab. And so we're all familiar very much with the approaches to the CP angle and the petroclival area. We have a variety of approaches to reach this critical and very tight space. And we can use them, alone or in a combination, subtemporal approach, a transpetrosal approach, and their varieties, the retrosigmoid approach, and of course the far lateral and the suboccipital approach. And we're all familiar with most of the skull-based surgeons, of course, familiar with the indications for selecting each approach to the lesion. And usually, I think, is the extent and the type of the lesion present in this area. And this slide is just to show that all these lesions come in variety of sizes. They come in a variety of complexity in their extent, where they invade the compression of the brainstem, the plane from the brainstem, their encasement of the very, very important neurovascular bundles in the CP angle, and their extent to other areas beside the CP angle and the petroclival recess, like the cavernous sinus, the middle cranial fossa, etc. And this is the challenge. This is the challenge in how do you select the appropriate approach for all these cases. And these are the meningiomas, which of course are the most common lesion or tumor present in the CP angle or the petroclival recess. And they present a formidable, challenge to the skull-based surgeon. But, we can't deny the importance of the retrosigmoid approach. And most of the cases, I think, can be approached through the retrosigmoid approach. And it's a very, versatile approach. We can use them with a wide exposure from the trigeminal nerve all the way down to the lower cranial nerves. And but again, as it has been alluded that using the transpetrosal approach in selected cases can have an advantage in the extent of resection and the nerve functional cranial function of the cranial nerves, specifically the acoustic and vestibulocochlear bundle and the lower cranial nerves. So this was a study that has been done over the last years of patients that we underwent surgery for petroclival meningiomas and other lesions. And we wanted to analyze how much we were able to extend the extent of resection, as we call a safe maximal resection or a total gross resection. And this is in comparison to the retrosigmoid approach. And how did the patient do after surgery in terms of their cranial nerve function? And other petroclival lesions that we used to include in this study were also clival chordomas, chondrosarcomas, and other trigeminal schwannomas extending into the CP angle or the petroclival area, epidermoid tumors, and lastly, some challenging cases of a delicooptatic, basilar artery causing trigeminal neuralgia or vascular lesions and large brainstem cavernomas. So again, we cannot deny the versatility and the utility of the retrosigmoid approach to the CP angle and the petroclival area. It is such a quick approach, very familiar to all neurosurgeons, very easy to relax the brain from the cistern and relax CSF, get a panoramic view to the whole posterior fossa from the tent all the way down to the foramen magnum. And this is one case, I don't think many would disagree or argue about using the approach, this retrosigmoid approach. In this case, this is a 31-year-old female presenting with headache, left-sided sensory neural hearing loss, and left trigeminal hypothesia. And again, as explained, the retrosigmoid approach is a very familiar approach to all of us. These images or representations are from the Jackler's Atlas, and just with the minimal retraction or no retraction now with the modern neural anesthesia, and using maybe a lumbar drain or draining CSF, we can get to a far reach into the CP angle resecting vestibular schwannomas or meningiomas. And this is the case. We can see that it's a quite sizable meningioma that's occupying the left CP angle and extending all the way to the petroclival recess, and with the compression of the brainstem, and quite closely related to the trigeminal, facial, vestibulocochlear, and lower cranial nerve. All of them are compromised or encroached upon by the tumor. And again, you quickly get to the tumor, which makes surgery much more faster, I think, and usually, and I was trained of course, as everybody knows, about the importance about the lower cranial nerves as a functional outcome for the patient, and I quite very careful about dissecting the lower cranial nerves off the tumor, get them using the arachnoid plane, not causing any traction. And then, you release CSF, relax the cerebellum, and you then get to the meat, the meat of the tumor, debulk, and then it's a cycle of, devascularizing, coagulation, debulking of the tumor until, you get to have a sense that you're almost controlling the tumor. And with enough debulking, you can start to manipulate the tumor off the brainstem. And I usually, with these sizable tumors, you get really sometimes stuck in some areas. So I go to another area that's less challenging, or the plane is more, feasible to dissect. And I think that decreases, fatigue and the need for, very focused concentration in all the time of the surgery. So alternating that gives you, some encouragement. And if you can debulk, quite sizable pieces of the tumor quickly, that makes you less vulnerable to surgeon fatigue at the end of the surgery, where very much of the critical, steps of the surgery, like dissection of the brainstem and of the cranial nerves, is required. And you can do that with relatively still with a lot of concentration and less surgeon fatigue. So, you continue to dissect tumor, and then you get to the level at the brainstem where, every single step of the surgery here can make a difference as regards, perforators of the basilar artery and, the plane of the brainstem. And you get to try to do as much as you can resecting this tumor and decompressing the brainstem and preserving, the cranial nerves. And you can see here that the lower cranial nerves were preserved, the facial and the lower cranial nerves and the trigeminal nerve all had a good plane, as well as the brainstem. And this is the post-op. And this was a near total resection with some of the dura involved at the petroclival recess, and of course getting into the cavum trigeminal. But I think this is a very reasonable resection, and it can give the patient the longevity of not suffering any morbidities from the tumor, and with a functional outcome that is wouldn't affect her daily life and activities. And this is the patient, after 3 months of follow-up, she had some facial weakness, but other than that, she was doing well. Other lesions that the retrosigmoid is very useful is sometimes, of course, the challenging situations of having irresistible trigeminal neuralgia patient that doesn't respond to medications. And this is one of the patients I had that had this delicooptatic basilar artery, and he didn't have any relief from any medications. And again, the retrosigmoid approach gives you a panoramic view, and you need to decompress this artery, all through all the cranial nerves and have a good panoramic view of the surgical field. And I thought, just showing this case, and it's not, of course, a tumor or a meningioma, but it shows you that the retrosigmoid approach is a very versatile approach to any of the variable lesions, and of course the very challenging ones. And we can see that after dissection of the arachnoid and cutting into the cistern, you can expose this very large delicoectatic basilar artery, and we can see how it's compressing the trigeminal nerve, pushing it upwards. And you need all the space and all the, triangles, or if you can see access routes to decompress this basilar artery off the trigeminal nerve. And in this case, I thought like just padding it with Teflon patches is not going to be enough. And as you see, pulsations even against the sucker is so robust. And once you remove the sucker, it goes back up, against the trigeminal nerve. And so meticulous dissection and exploring all the small perforators of the basilar artery, I thought we can do what we call like a sling technique, and anchoring this delicoectatic artery away from the brainstem and away from the trigeminal nerve. And that's what we're doing here, exploring the undersurface of the basilar artery, and just using a sling technique used from like a modified vortex here. And in an area that is perforator free, and I think that's the major risk of this technique, I was able to, perform this sling around the trunk of the basilar artery, and just gradually making this sling around it, and anchoring it to the dura of the petrosal. And just, pulling on it would pull it away from the trigeminal nerve, and coagulated the dural surface of the petrous bone, cut it with the 11 blade knife to make like area where an aneurysm clip can basically clip this the edges of this sling to the dura, and just trying to know the extent of the retraction required before applying that clip, and seeing how this technique would help pulling away that basilar trunk away from the trigeminal nerve. And again, I think the major importance here is to avoid any perforator avulsion of the undersurface of the basilar trunk going to the brainstem. And I think this is just showing how to, troubleshooting this technique and showing how much retraction is needed. And eventually, I think we had a good, pulling forceps of the basilar away from the trigeminal nerve, and even away a little bit of the, vestibulocochlear bundle and the facial nerve. And then we apply an aneurysm clip to this leaflet of the dura that we dissected off. And of course, this is all under MEP and SSCPs, just to know if there's any change in signals. And with that, this decompression was successful, and the patient didn't have any further pain. Also, exploring, the undersurface of the trigeminal nerve, making sure there's no other vessel there. But I think the culprit here was definitely the delicoectatic large vertebral basilar. So going back to tumors, when to think about, tailoring your approach to the CP angle or the petroclival recess. And using the anterior petrosectomy or subtemporal approach, I think for me, when the tumor is extending into the middle cranial fossa and is large enough that would give you, the access required to the posterior fossa, this is my thought process when, thinking about the anterior petrosectomy or anterior transpetrosal approach. And I think the major thing about, disadvantage of this approach is there's always a hidden part in the posterior fossa that, under the cliff of the petrous ridge here that you can't see or is blind. And if the tumor is solid enough or fibrous enough that you can't bring it out as one part or see directly, there's usually a residual. This approach with a subtemporal craniotomy and going subtemporal and dissecting the dura off and follow the greater superficial petrosal nerve and getting into the prepontine cistern and resecting the tumor. And this is all well described in Roten and Jacker Atlas and multiple publications, and drilling out the Kawasi's triangle and exposing the posterior fossa dura. And I think also this is very, very, I think, multi-layered in complexity. Even if the approach is very quick and relatively, with limited anatomical landmarks, but again, you can easily lose where you are if you're not trained. And here comes the importance of the training in a cadaver lab, dissecting and mushing up skulls multiple times until you get the sense of not just where the anatomical landmarks are, but where is the orientation of these anatomical landmarks. The trigeminal nerve is, how is it lying on the bone, its trajectory in a 3D manner, the petrous apex, its thickness, how do you see or differentiate dura, and getting the sense where is the nerve, the GSPN, and, orienting yourself to the Kawasi's triangle. And it takes time to do that in a cadaver, but even after you master that in a cadaver, doing this in an actual surgical field with blood and a different texture of tissues is another challenge that really requires a lot of training. And this is the final view where you can see, anterior to the brainstem and, as described, the lower limit of this is tumors usually at or above the internal acoustic meatus, and we do expose a good size of the tumors there, and reflecting the tentorial leaflets and cutting them, making sure not to injure the trochlear nerve, and identifying the trigeminal nerve from the brainstem into the porus and decompressing the brainstem and removing the tumor. And this is the final result. I'm going to skip that video for the sake of time, but this is the final outcome. And usually, for me at least, I think leaving a small residual in this blind spot that I mentioned is what I realized doing this approach. And this lady had a good resection, but of course, there's this residual in the petroclival recess, and she was diagnosed with a chordoid meningioma. And we continued to follow this residual, but it continued to grow. And as it grew, I thought like compressing the brainstem and having further symptoms from this compression, I decided to go through an posterior transpetrosal approach for resecting this residual that continued to grow despite radiation. And accessing this petroclival recess was much easier doing this posterior petrosal approach. So again, it's all about customizing your approach to the specific location and the specific circumstances of this tumor, which are all very variable and very different. So going to the main, topic of this presentation about the posterior petrosectomy. And I think the posterior petrosectomy is a workhorse and takes significant time in the OR, and you got to have a good teamwork with a skull-based team doing these cases with the neurosurgeon, the neurotologist, and a very understanding neuroanesthesia team and a competent, post-operative ICU for all neurosurgical cases. But this is a long, lengthy procedure to get just to the place that you want to start working. And in comparison to the retrosigmoid approach, you get to the tumor after probably half of the day is gone if you start early, and you're going to start working on the critical area, later in the day. And of course, you have a partner with neurologist. Again, these have to be selected in specific situations, and where you think it's going to be better for the patient to do the surgery, get a meaningful resection, and preserve his functional outcome using this more invasive approach. And so just showing some cases, this is a 56-year-old female with headache, trigeminal pain, hemiparesis, and swallowing difficulty. And this is her tumor. It's a very, very sizable tumor that's, compressing the brainstem, encasing the basilar, even reaching the other side of the petroclival recess, and going up towards, pushing up the tentorium and affecting, significantly her, her causing a lot of morbidity. And using the retrosigmoid approach, you can get there, but it's such a long reach and crossing, all the cranial nerves, getting so anterior. I thought like a shorter procedure, approach to this tumor would give me a better direct, and better control tackling this tumor. And so during, doing these posterior petrosal approaches, you can do it in two ways or multiple ways, I guess. I was trained at Mayo Clinic with Mike Link, my mentor, and that we can do this through, a single craniotomy. And this is a subtemporal and retrosigmoid craniotomy, and crossing over the transverse sinus. And with that done, you expose the temporal or subtemporal dura and the posterior fossa dura, and then your otologist partner comes in and does the mastodectomy. And depending on how aggressive or how customized you want to do the approach, you can use the different varieties, the retrolab, translab, transcochlear approaches. And again, if it goes really anterior, you can do the transcrucial approach, where you drill part of the superior semicircular canal in the posterior. And if you want to preserve hearing, you want to plug those really quickly to prevent leak of lymph. But with that exposure and opening of the three sigmoid dura, you release CSF, and with opening of the subtemporal dura, you're exposing, the area or the whole field to connect. The whole purpose of this is to connect the infratentorial with the supratentorial space by cutting the tentorium. And that, of course, is done by initially controlling the petrosal sinus, and then cutting the tent, which is pretty vascular, so it needs a lot of coagulation, followed by cutting. And at the end of your cutting, scope, there's the trochlear nerve, which you want to make sure you don't nick while cutting. And of course, the vena blebbae at the posterior aspect of your exposure, especially can be compromised with lifting of the undersurface of the temporal lobe. And with that, you get a really panoramic view of the posterior fossa, and where the tumor resides. And I think it gives you a better control or access to, all elements of the superior and the inferior medial and lateral aspects or extensions of these tumors that can easily invade the cavernous sinus or get into Meckel's cave and significantly compress the brainstem and the cranial nerves. Further images like cadaveric dissections, again, you have to do this a lot in the cadaver lab and understand the anatomy. And these are all, variations of the, mastodectomies and transcochlear or retrolab approaches to this area. And the aim is to get so much anterior that you're seeing the petrify recess. And you can do that with an intact fallopian canal or leave the fallopian canal. Depends. Most of us don't reroute the expose the facial nerve in the fallopian canal because of results of facial palsy. But this is the case. We put her in a lateral position, use a lumbar drain, and the incision and steps as alluded. You expose the temporal and posterior fossa dura, bridging over the transverse sinus and exposing the anterior dura to the sigmoid sinus and opening, the dura there and exposing the tumor. And it's a direct access to the tumor. You can see all of the anatomical, landmarks that you need to recognize, and you start debulking the tumor. And this is one of the very first cases. But again, this is such a large tumor with a lot of encasement of the basilar artery, the perforators. So it depends on how this is really, attached to the brainstem and these perforators, how aggressive you want to be, because a single perforator can cause formidable morbidity to the patient in this area. So we had a reasonable resection. I wouldn't say it's the best resection, but it's a reasonable resection with the goal of the brainstem decompression. And she was diagnosed with a transitional meningioma, the grade 2, had radiation, and kept doing well. And this tumor residual didn't grow with follow-up. And she had a little bit of a hemiparesis after surgery, especially in the arm, that improved with physiotherapy. Another case where again I see that the tumor is very anterior, compressing the brainstem and high enough that you would want to do this direct access to the tumor, presenting with headache, hearing loss, trigeminal hypothesia, and gait imbalance. And again, I think you can do this retrosigmoid, but sometimes surgical intuition can also help in deciding these when it's equivocal. And this is what we do. Again, modified the skin incision to go a little bit anterior to the ear and removing this bone as a single piece, bridging the transverse sinus and getting into the presigmoid dura. And this is the exposure under the scope. We open the presigmoid dura and release, the CSF. And that really helps in getting things much relaxed and calmer. And you can get an initial exposure of one of the cranial nerves. It could be, usually the vestibulocochlear and the facial nerves. And then with that relaxation, I open the temporal dura, put a gentle retraction just supporting the temporal lobe and making sure that I know where the vein of Labbé is, especially if it's on the left side. And then, cutting the tent all the way to the brainstem and retracting, the leaflets of the tent. And this is the intraoperative monitoring stimulating. And then you get you get to this the tumor, and it's in the middle of your field. It's not such a long reach as the retrosigmoid approach, and you have the cranial nerves, above and below. I think you're not working across the cranial nerves, and I think that's the major advantage. And you have control of the tumor, and you use your whatever you have in your OR armamentarium with CUSA, bipolar, and microdissection. And you get to this area where the petroclival recesses were very anterior you want to be. And again, better, shorter distance and better control of the surgical field dealing with these basilar perforators is of paramount importance. And at the end of the surgery, the interface with the brainstem was not the best, and we thought leaving a cuff of tumor off of on the brainstem was advisable to them, and putting some gel foam for hemostasis, and that's the immediate post-op imaging with a cuff of tumor on the brainstem, and reconstruction with fat, and she had a good total resection with a good functional outcome. She didn't really suffer any facial weakness or any hemiparesis or anything. When the tumor goes all the way down to the foramen magnum, I think nobody would disagree that combining this retrosigmoid approach with doing the far lateral approach would give you better control. And again, this is very useful to be done in the cadaver lab, as you know, and dissecting, knowing the triangles, the muscle layers, C1 and where the vert would enter. All of this is very, very advantageous to do in the lab multiple times to feel more comfortable in the OR. And I use the hockey stick incision to park bench and having a Mayfield. You shouldn't need to do a long working as you have access, to the cistern. But you can get a good resection. And this lady had a near total resection and good outcome, but a lot of immediate post-operative imbalance. And she had needed extensive rehabilitation and vestibular rehabilitation after surgery. So when we want to combine, the anterior or posterior petrosectomies to do a total petrosectomy, and I think for me, customizing this approach to a lesion is where you find a lesion so anterior or in the midline, and not giving you, a side to choose, and you want to go so much anterior that you want to use multiple routes, I think, to access this tumor or to be anterior to the cranial nerve. Who planted this with also, some complaints of headache and gait imbalance, and it's really centered. I think maybe you would call it a clival meningioma. It's centered in the midline, and sometimes we use these combined approaches for tumors like dumbbell-shaped trigeminal schwannomas or petroclival meningiomas that have presence in multiple compartments. But also for me, I would like to use this approach when tumors are so centered anterior on the clivus. And again, these are the images from Roten Lab and how you would orient yourself, with the anatomical landmarks, and how would you want to, know all the important varieties of the and knowing, all the details with your neurotologist about the masculectomy, I think, is also very important. This is just more images of how you want to expose the pre-sigmoid dura and exposing the surgical field. And I think, with these tumors, the more windows you have to attack the tumor, especially if they are sizable, which are usually the case where I previously practiced, patients present late with sizable tumors. You want to have multiple options where you can approach this tumor from, in between different, cranial nerves, and also from different trajectories, either anterior or posterior through the petrous bone. And this is the case, we did the subtemporal craniotomy and the, anterior petrosectomy and exposed the anterior petrous bone. And this is drilling of the petrous bone, or the petrous, anterior petrous triangle. And again, draining CSF from the pre-sigmoid dura, and initial exposure of the tumor and a cranial nerve, which usually can be 7 or 8, or the trigeminal nerve, and then opening the temporal dura, and cushioning the brain there, and exposing the tent. And I think putting the retractor here is very important and can facilitate a lot your exposure to the the axis where you want to cut the tentorium. The key here is not to put a lot of traction on the temporal lobe, because you can end up with contusions to the undersurface, or you can avulse the vein of the bay, and then a gradual cutting of the tentorium, and making sure at the last part of it that you see the trochlear nerve, and don't nick it with your micro scissors. And with that, you get very good exposure to the whole surface of the tumor, and you start, orienting yourself. Where are the landmarks? Where are the important structures you want to preserve? Another tip, I think, during the surgery is that you want to release the trigeminal nerve entering the cavum, because you're going to mobilize the trigeminal nerve, which is usually in the middle of your field, and you want to work around the trigeminal nerve, and you don't want it to be hinged on where it can be hinged at the porus of the trigeminal cavum. And then the tumor here, is in the middle of the field. I think a shorter working distance, the illumination is much better. You don't get really fatigued stretching your arms, getting into this really, tight space. And when the tumor is vascular, then you need a lot of coagulation, to keep the field as dry as much. And this tumor is quite bloody. So there's a lot of, alternating cycles of coagulation, dissection, and resection. And after a couple of hours, that can cause a lot of fatigue. And you want to minimize that to the least, where you want to work on the very sensitive areas at the brainstem, the cranium, and the cranial nerves that you want to preserve. So, debulking the tumor using micro scissors and CUSA, followed by, bipolar coagulation to keep the field as, clean as possible, because, the critical part is getting at that plane where you want to really preserve all these small perforators. Paramount importance to keep all these very small vessels, which are very small in comparison to the size of the tumor. And the field has to be as dry as possible to preserve every single one of them, as they have devastating effects if you avulse or injure. And this is the benefit, I think, of this approach. You can work above the trigeminal nerve, debulk the tumor there, and then the size, the tumor going, in different trajectories or different areas, you start to have other and again, repeated cycles of coagulation, making the field, and that's the basilar artery at the brainstem. and you can, with significant debulking, remove pieces of the tumor where you have resected most of it into the places that you have enough space that you can juggle the tumor from one window to another, and this is the final outcome where you I think we had a good resection of this tumor. The plane was good off the brainstem, and we usually reconstruct with natural or tissue from the patient using fascia larga and fat, and followed by tissue or whatever we use to um, reconstruct all that bone and put it back. And this is the case. I think she had a good total gross total resection of her tumor, and no residual on follow-up. No complications related to CSF leak or anything, and immediate post-op, you can expect some morbidity with facial weakness, and she had an abducent, but with follow-up, I think that was much better. Her abducent resolved completely, and she still had some facial house pattern to weakness. And I think that's the advantage, I think, from the Petrosal approaches, that you would expect that the nerves would, adapt or will be able to have some sort of resistance to all the manipulation around them, going, anterior with the transpetrosal approach, then working through them and causing all these, mechanical injury, just working through them for such long hours. And using the transpetrosal approach also for other lesions, like this case with a gentleman young in age, 30s, had this large clival chordoma. And again, you can use the extended endoscopic, transclival approaches for using these resecting these tumors. But where I practiced, I think it was safer for me to resect this tumor through a transpetrosal approach. I thought it digged so deep into the brainstem with the intradural component, and the reconstruction methods and everything were not as mature that I would have liked. So I thought having a CSF leak or something, doing an anterior approach is such a concern for me. And so I used the posterior transpetrosal approach in this case, and just show part of this video. Again, you have a direct access to this tumor where you are anterior to the brainstem, and it's much more pleasant, of course, working on a clival chordoma than a vascular meningioma. But it's not about just controlling the tumor, but it's again reaching this lateral extension of the tumor beyond the internal acoustic meatus on the imaging. And I thought, you really need angled endoscopes, and which are of course available and doable nowadays. But I thought in my hands, just going through a lateral approach would be a more meaningful resection for this patient. So this is his outcome, his post-op MRI. We saw he had a small residual in the intradural part that was really stuck to one of the vessels, and his extradural part. I thought like we can follow that up and see if that grows, and it didn't grow on follow-up, and we're still continuing to follow this patient with a good functional outcome. One of the cases that I done here in the UAE at SSMC, this patient had this large cavernous malformation in his brainstem. He came in a wheelchair, hemiparetic with an abducent palsy and facial weakness. And again, you know, I thought using a transpetrosal approach would give me the access that I want to get into this anterior bulging cavernous malformation. And we did a combined petrosal hearing preservation retrolab approach with navigation guided and intraoperative monitoring. And this is his intraoperative, steps. We exposed the temporal bone, the retrosigmoid bone, and did a craniotomy that crosses or bridges the transverse sinus. And then Dr. Mondi, our neurotologist at the time, did the mastodectomy. And this is the final exposure. And again, you can get access to the anterior surface of the brainstem. And what you see here is the trigeminal nerve. And after stimulating, and getting into, the entry point that you want to see some hemosiderin at the surface of the brainstem, you get this gush of liquid of blood. And as you go on and you suction, this cavity continues to enlarge. You don't have to widen this entry point. And at the end we were lucky to have very good resection of this cavernoma with no change in any signals with his intraoperative monitoring. And again, I think getting to this lesion through a shorter route means more, with more efficiency in resecting it. And also, I don't have to get into any of the, cerebellar tissue or middle cerebral peduncle or get lost. It's a sizable cavernoma, maybe smaller ones. You can get lost if your navigation is off. But it depends on customizing your approach to resect these challenging lesions in this very tight space. And we were lucky he had no deficits and his hearing was preserved. And very happy with surgery. And he came back, his abducent took 3 months to resolve. He was on a wheelchair. Now he's walking and some residual weakness on his contralateral side, but that's much improving, and I call him my bravest patient. And at the end, I would like to, very thank my very, very close friend, Dr. Ahmed Hisham, our neurotologist at Alexandria, where most of these cases were done. And thank you very much for your time. Just a quick note that at the end, I think total resection was achieved better in the transpetrosal approach. And I think the facial outcome and the lower cranial nerve outcome was better in the transpetrosal approach in comparison to the retrosigmoid approach. And I think that is attributed to the shorter working distance and allowing better exposure of the field with better surgical precision and less direct manipulation of the facial nerve and the lower cranial nerves. We been doing these in a two-staged approach, where we do the approach one day and take the patient back the following day to start fresh on the tumor or the lesion. Of course, this is in large meningiomas, and this was tolerated very well by all patients. Thank you very much.
Congratulate Tarek. It's a wonderful presentation, very nice case. No, your conclusion is the conclusion that you have better exposure, you can remove more, you can be safer, but does not mean that you need in every case. For example, if you see meningioma is one thing, epidermoid cyst is another thing, schwannoma is different, chordoma is different. For example, for chordoma, the majority of time we use extradural approach, come from outside to inside. In the epidermoid, the majority of the time, the tumor gives you the approach, and the brainstem doesn't come back, the cerebellum doesn't come back. You have the whole space, but you have situation that maybe can go to the other side in the petrosal team. For meningioma, the most important thing is to know where is the attachment, the main attachment of the tumor. We are seeing the people doing petrosal approach when the attachment is in the petros apex, is more anterior or more posterior. Maybe this you don't need. But when it's in the clivus, medial to the fifth nerve, maybe we need to come more lateral and lateral. One thing that you said that the end that you do the approach one day, you do the surgery in the other day. With the time, you're doing more and more and more, you learn how to do the short way, and the approach is improving. You can do. I do the one step, okay. I do the approach, and I do by myself and continue. I take the whole day, try to remove the cave, but with the time you can get more experience. You can do more and more and more. I truly believe that. Understand the skull-based surgery, understand the Petrosal approach. You need to go to the lab, you need to go to the microsurgery lab and learn and study and study. So if the time, I would say, when I came back to Brazil, I was doing a lot of cranial orbitozygomatic approach, orbitozygomatic. Now I'm doing less and less, because I learned how was the route for each situation. The Petrosal approach, and the classical Petrosal approach, I'm using less. However, to use the Petros bone as a root, I'm using more and more. Use the anterior Petrosal, remove a little bit more the Petros bone to expose the sigmoid sign. You have more lateral view. Maybe sometimes you need to come posterior, subtemporal. See, I did last week 2 cases, craniopharyngioma children, one 6 years old, other 8 years old, retrochiasmatic. When Hakuba published this many years ago, was very confused, because the idea was very interesting, but the illustration was difficult, the English was more difficult, and it was confused. And Dr. Omefti I think 2010, 2010, published a new version of this. And I was the guy that was commenting the article. And I wrote there, very nice idea, but what is the case that do that? But now, see, if you use this posterior part of the temporal lobe, remove part of the Petrosal, just cut the tentorial and come in that direction from posterior to anterior, you can reach very well this retrochiasmatic craniopharyngioma. You don't see the nerves, you don't see the artery, you go directly to the tumor and do that. But this we learn with the time. With the time. And the experience makes the difference. The experience. But for the young generation, I want to say that if you go to the lab to do transnaval, it's very good. Go there and learn. But also go to the temporal bone. The temporal bone is the only surgery that you reproduce totally. What you do in the lab is the same in surgery, because it's bone.
Yes.
See? Yeah. If you start to do that, I think it will be great. I'm very pleased and very happy to be here to see this kind of presentation, Raja. Thank you, Raja. Thank you, Professor Kato, to bring this back. The Petrosal approach is not dead. The Petrosal approach just changing the way that we see. But it still is a great route to reach the skull base. Sorry to talk too much, but I'm in boarding now to my city. I really appreciate your presentation. I cannot stay a little bit longer, but thank you very much for the opportunity to be with you. And Raja, anytime I'm available to you. Okay? Thank you very much. Thank you.
Well, thank you very much, Prof. Barba, and we are extremely grateful to you. Despite your very busy schedule, you took out your time for us. We are extremely grateful. Thank you very much. Have a safe flight. Bye bye.
Thank
See
you.
you.
Thank you. Bye bye. Thanks.
Thank you,
Bye.
Professor. Thank you.
So if there are any further questions from our other panelists, Dr. Ben, would you like to ask something?
Yes, and thank you, Professor, for your excellent explanation in the lecture and summing up your experience in doing the preachers and also the temple bone. And thank you so much. And I agree with the Professor's Louis Burber's comment that this approach is not that yet, and I think the most difficulty is there are so many variations with this approach. There are so many names, for example, like the transclavicular, retrolab, translab, and petrosal, and those are variation with this. And I think going back to the lab is the only way to start learning this, and then before you practice I should not practice, before you apply this knowledge to real patients. My question is that when you are doing a real case for the anterior petrosectomy, any tips for reaching the most anterior extents of the drawing of the anterior petrous bone? Because sometimes for the beginners that they don't reach the most anterior extent, which is the inferior petrosal sinus, I think. Please comment if I'm wrong. But sometimes during the surgery, you don't know where you are. So sometimes the navigation might be, for posterior fossa, the navigation sometimes is not correct, and sometimes we don't know whether we have drilled enough bone to gain the exposure that we should have. Any tips for the young neurosurgeon, Professor?
Yeah, thank you so much for your question. It's a great question, and I think every skull base interested surgeon passed by this experience that sometimes you get lost. You're not sure about the anatomical landmarks, and again, I think what I learned from my fellowships is that you have to plan for plan B. If your navigation is a little bit off, or you're not very familiar, or you get lost. You're familiar, but you get lost. I think the cornerstone of getting reoriented is having the sound anatomical knowledge, and this is, you go back to the landmarks where you see the GSPN, you see the bony landmarks, and look for the carotid, orient yourself to the Kawasi's triangle, and again, you can't get to that level of going back to the basics if you don't do this in the lab many times, and every time you're going to add a little bit of more orientation to yourself as regards the anatomy in that, because the subtle variations with every skull, with every head during surgery, if it can get you off, and you really need to have the sound anatomical training in a cadaver lab. I call mushing all the skulls up, getting all that bone dust, and looking at different variation of bone thickness, bone quality, dura, GSPNs, width and length, if you can see it or not. Sometimes it's just a flimp of something. Sometimes it's very well, very well demonstrated in the cadaver. The degree of dehiscence of the carotid, the angle, where you want to see where the IAC, the angle, the cochlea, all of that, you have to again and again orient yourself, in the cadaver lab. And once you're confident enough that you can go back to these anatomical landmarks, even if you get off during surgery, you're not really sure if you drilled all the bone and you got to the inferior petrosal sinus or not, you can go back to these anatomical landmarks and reorient yourself, and that's the only way, and you're in the middle of the case now. You can't go back, but it reassures you that you are on the right track, even if you're a little bit off or something strange or with a distorted anatomy, with a big tumor or something, or with lesions that are eating the bone. You can face multiple challenges, affecting skull base lesions. But again, getting to the inferior petrosal sinus, you get to the dura, and and that's where you see the inferior petrosal sinus, and you have to make sure that you secure that well. Again, bleeding from that and from a very tight space or a very tight exposure is not the best experience. And then you open that and get to the prepontine cistern, and voila, you have the exposure that you need. But like even doing that cavernous malformation, sometimes, in the brainstem, you did the approach, you're exposing everything, and then, well, where is the best entry point to the brainstem, for example? You reorient yourself. Where is the trigeminal nerve? Where is its exit route? You have your probe and stimulation, but again, it's the anatomy, I think, that makes you more comfortable in taking decisive decisions of where do you want to continue, in your surgery.
Thank you. Thank you so much.
Thank you. Thank you very much, Dr. Jan and Dr. Ben. Regarding the transpetrosal approaches, where this has been most famously done by in the original place where it was described in Osaka. It was the Hakuba, then later Dr. Ohata, and now Prof. Takio Koto. The three very striking differences I noted between them and your work is, one is they take the pedicled flap at the beginning of a craniotomy, where it is on the mastoid based, and they take a whole pedicle flap which they keep it back at the closure.
Yes.
So that is a very useful thing they do. Another thing they do is that they split the mastoid. The outer cortex of the mastoid is taken out, and then they go for the drilling of mastoid. At the end of it, they replace the mastoid back, the outer shell, so that they get a very good closure. Cosmetic closure is very good. And the third thing is the emphasis is on the mobilizing the sigmoid sinus back to get the space. So the cutting of the SPS is so much emphasized there, the where to cut, so that the drainage of the petrosal vein is preserved. So they always say they cut as far as anterior at the level of the Meckel's cave even, so that the preservation of the drainage of the petrosal vein is there. So do you have any tips for the cutting the SPS ligating? Where do you do any specific tricks or tips for that?
Yeah, I think going as anterior as possible is the advisable thing to do. But sometimes you have like huge tumors that are invading the cavernous sinus, and you can't go so anterior. I think as long as you're controlling the superficial petrosal sinus well, you're away from the vein of Labbe, which is usually much more posterior, and the trajectory is all the way through perpendicular on the tent, all the way to the tentorial incisura, and I think you're fine. I think the best thing for me that I found is you want to have a little bit of a leaflet to put a stitch in and retract. You don't want to really cut it so anterior. You don't have any. You can use that in your advantage, and retracting these leaflets anterior and posterior, and giving yourself maybe a more spectroscopic view of the field that you want. But I haven't found really much difference if you go a couple of millimeters anterior or posterior.
Well, that winds it up, and thank you very much for this very wonderful lecture that you gave us. We learned a lot from hearing you. And I would like to close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kata. I would like to thank both speakers of today, Prof. Lee Kiang and Dr. Tariq Ran, as well as the chairs, Dr. Luis Baba and Prof. Makoto Sakamoto for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 860 people who have logged on from all different channels, YouTube, WeChat and Zoom, to view this webinar. Also, special thanks to my co-host Dr. Libun Singh from Malaysia and Dr. Ben, who joined us from Hong Kong. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.